right, so going into the thrombophilias. So remember we talked about earlier, right? So we have this delicate balance between our coagulation factors and our inhibitors of hemostasis. So remember, on one side, we have our coagulation factors, and on the other side, we have our inhibitors of the coagulation cascade. Things like protein C and things like protein S, as well as antithrombin 3, right? And so if I tip in one direction or the other, I can end up potentially in a prothrombotic state where I'm kind of at risk for things like DVTs, things like pulmonary embolus, right? I'm just going to put DVT here, PE. And then on the other side of that, I could be in an anticoagulated state. If I tip too far this way, right? I could be in an anticoagulated state, and then I'm worried about bleeding potentially, right? If I tip too far. Okay, so again, this is all in a delicate balance. So in this video, we're mostly talking about what happens when we tip too far this way. Okay, what happens when we tip too far this way? All right, so let's go through that a little bit. So the first thing on here is going to be antithrombin 3 deficiency. Now, you can imagine, right? We just said antithrombin 3 is going to be an inhibitor of hemostasis. If I don't have antithrombin 3, right? If I don't have it, well, what's going to happen? I'm going to tip this direction, right? Because I don't have something that regulates the coagulation cascade. So I'm going to tip into a prothrombotic state. And that's exactly what happens here, right? If I don't have antithrombin 3, we already said the major two factors, the big two that you really want to remember when you're thinking about antithrombin 3 is going to be thrombin and factor 10A. Okay, those are the primary sites that antithrombin 3 is going to act. Now remember, heparin comes in when you talk about antithrombin 3. Heparin normally will increase the effects of antithrombin 3. Now remember, antithrombin 3 also inhibits a lot of other factors. Primarily, when I'm looking at the effects of antithrombin 3 and talking about heparin, which like we said increases the effects of antithrombin 3, we're usually going to measure these effects by looking at the PTT. Okay, so we're usually going to look at the intrinsic pathway. And what I would expect, if I give a patient heparin, I would expect this patient to have some elevation in their PTT because the antithrombin 3 is primarily going to be acting at the level of the intrinsic pathway and also some of the common pathway, depending again on which type of heparin we're giving, et cetera, et cetera. But the big point is that again, we look at the PTT, right, playing table tennis indoors, right, in the intrinsic pathway when we're talking about heparin anticoagulation and antithrombin 3. Now, if I don't have antithrombin 3, which is exactly what happens in antithrombin 3 deficiency, right? If I don't have this, well, guess what? When I give a patient heparin now, will I expect the PTT to rise? Well, probably not. It might not rise as much. Depends how bad the deficiency is, right? If I don't have any antithrombin 3, we're really not going to see an increase in the PTT because heparin is acting at antithrombin 3. So the point is, classically in a board question, a patient will have received heparin in antithrombin 3 deficiency, but they don't get the rise or the expected increase in the PTT that you would expect when you give them heparin. That's very classic. And you might be saying, well, in what situation? Is there a classic kind of board question that we would get about antithrombin 3 deficiency? And the answer is yes. The answer is nephrotic syndrome. So remember, there's a lot of different types of nephrotic syndromes. The whole point with nephrotic syndrome is that we're basically spilling protein in the urine. And one of those things that gets spilled in the urine that we're losing throughout the body is antithrombin 3. And that's why when you have nephrotic syndrome, they say that you're in a hypercoagulable state. Okay, which is basically another way of saying that you're in a prothrombotic state, okay, because you're losing antithrombin 3 in the urine because your glomerulus just isn't doing a good job of keeping the protein in the blood, and instead it's getting filtered out. Now, in general, when you start to get questions on thrombophilias like antithrombin 3 deficiency, usually, it's fairly obvious if a patient has, like we said, a DVT or a PE, but sometimes you'll start to get questions where they'll have a venous clot in a really unusual place. Like, for example, if you had a venous clot in the hepatic vein, okay, so you need to be in a relatively hypercoagulable state for that to happen. And so this is classically known as Budd-Chiari syndrome, right? So all the blood kind of leaving the liver is going to get blocked. When you have a venous thrombus in the hepatic vein, that will cause a congestive type of liver presentation, okay, where you'll have rises in your liver enzymes, etc. The other thing you can sometimes see is the renal veins with clots, and this can sometimes end up causing a varicocele, okay, and I don't want to get too off track here because we have a lot to talk about, but this can be very painful. If you have a renal vein thrombosis, it can be acute onset flank pain, hematuria, elevations in the LDH, but the point is you can get kind of these unusual locations. Also, like a cerebral vein thrombosis would be another classic one in a board question, and that's their way of kind of telling you that this is a thrombophilia, type picture. Okay, and again, that's very general, but it would be very classic if you had a patient with nephrotic syndrome to have antithrombin 3 deficiency. Let's talk about factor V Leiden. So factor V Leiden, I always think of this as like a factor 5A that has armor on it. Okay, so like a factor 5A, but this factor 5A is just like surrounded by this really strong armor that prevents its breakdown. Because remember, protein C and S are going to form a complex that eventually target factor 5A and factor 8A for destruction. Okay, so protein C and S will try to target this 5A for destruction, but when it has the armor, it can't do that. And this armor is the way that I just kind of remember, this is the factor V Leiden. This is protecting it. If it didn't have that armor, protein C and S could essentially target this factor 5A and destroy it or inactivate it. Okay, but when it has this armor, it can't do that. Okay, and so that's what's happening here. So you have kind of like this resistant factor 5A. Now, the interesting thing about this is it's inherited and it's autosomal dominant, but there's incomplete penetrance. But again, it's a mutant 5A that's resistant to protein C degradation. That's the important point. Now, again, if we just go back to our scale here, right? So protein C is on this side, and if protein C is not able to act on this factor 5, well, I'm going to have more activated factor 5A, right? I'm going to have more activated factor 5A. More activated factor 5A is going to tip me in this direction. Okay, so that's where you get into the prothrombotic state. Now, why does this even happen to begin with? So technically, this is a single nucleotide polymorphism. That change then changes the codon for the amino acid. So it changes it from what was an arginine amino acid to a glutamine amino acid at the position 506. How high yield is it to understand that? Not super high yield, but it's something that I would kind of keep in the wheelhouse if you can. The big thing, though, is just remember that this type of substitution is a missense mutation or a missense substitution. So it changed it from an arginine to a glutamine. Okay, so that's the missense. You're swapping different amino acids from a change of one nucleotide. And again, same kind of concept, and this is going to be pretty consistent throughout. You can have these venous thrombosis in unusual locations. What's an unusual location? In the hepatic vein, in the renal vein, in the cerebral vein thrombosis. You can also have DVTs. You can have pulmonary embolus. Pregnancy loss, right, because of this hypercoagulable state. And again, this is really a constant theme for most of these. All right, the next one on here is the prothrombin G20210A mutation. So again, you just have to know this is the prothrombin gene mutation. That's the important part, especially for board exams. There's not like 7 or 8 different types of prothrombin gene mutations that you have to know for step 1. This is really the one. The point of this is that, again, prothrombin, if you recall, that's factor 2. So prothrombin is right here. Okay, so prothrombin, if I had a mutation for whatever reason that caused me to make a lot more prothrombin, right? If I had to make a lot more of this prothrombin, well, what's that going to do? Well, that's eventually going to get activated probably to form thrombin, and I'm going to end up in a hypercoagulable state. And again, it just goes back to our scale here, right? So just to clean this up, right? All I'm doing is I'm saying, look, what if I just made too much prothrombin? If I made too much of one factor, well, what's it going to do? It's going to tip the scale into the prothrombotic state. That's exactly what's happening. You have a mutation in the 3' untranslated region of the prothrombin gene. It's causing there to be overactivation of that gene. You make too much prothrombin. So again, same thing. You can have venous thrombosis in unusual locations, DVT, pregnancy loss, but the key is you just have to understand that this is all because you have excess formation of prothrombin. Okay, now protein C and S deficiency being the next one on here. So remember, protein C and S, the big thing that protein C is going to do, it's going to complex with protein S. We're going to target factor 5A and factor 8A. Now, if I didn't have protein C or S, if I had a deficiency for whatever reason, okay, could be a lot of different things. But if I had a deficiency of protein C and S, again, what's happening? Well, I don't have, just like we said, with antithrombin 3 deficiency, I didn't have antithrombin. With protein C and S deficiency, I don't have protein C or S for whatever reason. Well, now I'm going to tip things in this direction, right? I'm decreasing my inhibitors, so I'm tipping this thing now into the pro-thrombotic state. So that's essentially what's happening with protein C and S deficiency. So I have less breakdown of factor 5A and factor 8A, right, because I have a deficiency of protein C or S, and that increases my risk of forming a thrombus. Now, the thing is, if a patient has an underlying protein C or S deficiency, that's maybe not super severe, okay, but let's just say, for whatever reason, right, we have a patient that has protein C or S deficiency, and let's say that I start that patient on warfarin. Okay, now it's important. We haven't really talked about warfarin yet in this chapter, but let me just tell you what it does, and we're going to go into more detail on this when we talk about warfarin. We have this pathway here. So protein C and S, they're made in the liver. If I inhibit this pathway in some way, I want to know the things that have the shortest half-life are going to be the things that are first affected. To synthesize protein C and S, and along with these other 4 factors, 2, 7, 9, 10, what happens is I need this enzyme gamma-glutamyl carboxylase to essentially synthesize them and then get them out into the world, right? Basically out of the liver. Now, to do that, I need a cofactor. I need to use reduced vitamin K. Remember, this is, like I said, these are all vitamin K dependent. It has to be reduced vitamin K. Okay, so when I use a reduced vitamin K, now that vitamin K becomes oxidized, and I have to get it back into the reduced form to use it again. The enzyme that does that is epoxide reductase. Okay, so what warfarin does is warfarin will come in here and inhibit this epoxide reductase. It's going to inhibit this. So guess what? Once I convert that reduced vitamin K to oxidized, I can't recycle it. So I'm going to quickly kind of inhibit this process of protein C and S, along with factors 2, 7, 9, and 10 from being synthesized here in the liver, because I can't regenerate reduced vitamin K. And the reason I just went through all of that is the first thing that's going to happen if I give a patient warfarin, right? What has the shortest half-life? Protein C. So my protein C levels are basically going to be the first levels to really drop. Once the protein C in the blood, because I'm already going to have protein C in the blood, right? I'm going to have all of these in the blood when I give that patient warfarin. I'm just not going to be able to make any more of them. So when protein C runs out, I end up with a hypercoagulable state. Okay, a hypercoagulable state, because I've run out of protein C. So for a short period of time, when you give a patient warfarin, you're going to generate a transient hypercoagulability when you give a patient warfarin. Okay, it's very short, because eventually what will happen is you'll start to lose your other coagulation factors, okay, over time. Protein C is an inhibitor of secondary hemostasis. So you end up with a transient hypercoagulability, which is scary. The whole reason you're putting a patient on warfarin is to anticoagulate them, but you generate a transient hypercoagulability, which is why we bridge patients onto warfarin with heparin. And we're going to get to all of that. But the point in this video that I want you to take away, if you had a patient that had protein C or S deficiency, okay, now things are even worse, because if you have protein C or S deficiency, you don't even have any protein C or S, or hardly any potentially, in the blood to begin with. And now you're giving somebody a drug that causes a transient hypercoagulable state, right? So now it's going to be even worse in that situation. So what happens is patients that have protein C or S deficiency, when you give them warfarin, they're at even higher risk of this transient hypercoagulability, and they can end up with warfarin-induced skin necrosis. Now, in general, you don't have to have protein C or S deficiency to develop warfarin-induced skin necrosis, right? The whole reason you're getting this skin necrosis, by the way, is because you have this hypercoagulable state, and you're getting all these clots forming in these really small blood vessels, right? Because you're basically depleting your protein C and S. This can happen in a patient that doesn't have protein C or S deficiency, okay, again, which is why we bridge warfarin with heparin in most cases. But if you did have protein C or S deficiency, you're at even higher risk. So the classic board question will be a patient that has protein C or S deficiency, started on warfarin, and now has these like hemorrhagic lesions, right, ecchymoses, throughout the skin, and the warfarin needs to be stopped immediately, and the patient probably needs to be anticoagulated. Now, the other thing, just to kind of keep in mind here too, patients that are pregnant or on contraceptives can also have lower levels of protein S. So again, something else to just keep in mind. Now, you wouldn't usually be giving a patient that's pregnant warfarin anyway, because warfarin's teratogenic, but just keep in mind that these things can also lower the protein S level. The next thing on here is hyperhomocystinemia. So remember, we talked about this a little bit when we talked about macrocytic anemias, right? So homocysteine can be elevated in a lot of different vitamin B deficiencies. vitamin B6, B9, B12. We went through the whole pathway to kind of show how that happens. But the classic pathology that comes up is the homocystinuria. Okay, so this is usually due to a methionine synthase or cystathione synthase deficiency. These are the two pathways basically where you're able to convert homocysteine to either methionine or cysteine eventually. If they're not working, you can get a backup of homocysteine. The classic board question with homocystinuria is usually a patient that almost presents like they have Marfan syndrome. So they're going to have a Marfanoid habitus. Okay, so they're going to have really long limbs. They could have, be really thin, have pectus deformities, for example. But the thing that they're going to have that's going to make them stand out from Marfanoid syndrome, there's two things. The first one, usually these patients will have some kind of intellectual disability. Okay, so usually they'll have some kind of intellectual disability. And the other thing is, classically, this is the big thing to look for, they'll have a lens dislocation that's going to go down. That's the big thing. A downward lens dislocation, very classic for homocystinuria. Because remember, in Marfan syndrome, if the lens dislocation goes up, that's classic for Marfan. Okay, so lens dislocation up is classic for Marfan. So I remember the moon, the M in the moon with the M in Marfan. So the lens going up to the moon, that's for Marfan. So upward lens dislocation, classic for Marfans. If the lens goes downward, right? If the lens goes downward, dislocates downward, that's classic for homocystinuria, okay? And the way that I remember that is look at the end of the name in homocystinuria. It's urea. It's almost like urine, right? So I'm thinking about kind of downward urination, urinating, right? Those body parts tend to be more distal. Not quite as obvious, but the point is an upwards lens dislocation, classic for Marfans, downward lens dislocation, classic for homocystinuria. Now, homocysteine in general, right, we already said it's prothrombotic. Your patients are at increased risk of premature coronary artery disease, thromboembolisms, etc. So it's grouped in here with some of these hypercoagulable states. All right, the last one on here is antiphospholipid syndrome. So there's a couple classic antibodies, anticardiolipin, anti-beta-2 glycoprotein 1 antibodies, and then we also talked about the lupus anticoagulant. All of these kind of very classic for antiphospholipid syndrome. Usually the way this presents is it's going to be a female patient that has had, multiple adverse events with pregnancy. Maybe they had potentially a miscarriage, and it will tend to be usually a younger patient. And we talked a little bit about this lupus anticoagulant that gets very confusing when we talked about the hemostasis diagnostics. Remember, in vitro, when I test this patient's blood, their PTT might be elevated, but it's falsely elevated, right? This lupus anticoagulant falsely elevates the PTT. What's actually happening when I look in the blood in this patient is this lupus anticoagulant, along with some of these other antibodies, are activating a lot of the phospholipids. So they're actually causing a hypercoagulable state. Okay, even though when I look at the labs, the PTT is elevated, which is very confusing. What you can do is you can take normal plasma and you can take the patient's plasma and mix them. Okay, and what you'll see is that the PTT doesn't correct, okay, because there's not a clotting factor deficiency. The issue is that you have this lupus anticoagulant in the blood. And if you're not sure what I'm talking about, watch the hemostasis diagnostics video. I go into great detail on this process to clarify it. And the other thing in that video that I talked about is when a patient has this lupus anticoagulant or this anticardiolipin antibody, the patient is also likely to have things like a false positive syphilis test, especially the screening test, because of the cross-reactivity of the cardiolipin. So a very classic question is a younger female patient, maybe she had a couple miscarriages potentially, or some adverse pregnancy events. Maybe she had a history of a DVT also, and the patient also has an elevation in her PTT, potentially, that wasn't reversed by mixing studies, and she has a positive RPR. That would be a very classic board question for a patient with antiphospholipid syndrome.